Hello, everyone, and welcome to the National Action Alliance for Patient and Workforce Safety monthly webinar. We are thrilled to have so many of you joining us live and look forward to seeing how many of you will be watching the recording following today's session. My name is Fran Griffin. I'm a consultant with the Ripple Effect, and I will be moderator for today's session focused on implementing the CMS Patient Safety Structural Measure. Next slide, please. Just a few reminders before we delve into our presentation today. This session is being recorded and will be available for viewing on the National Actions Alliance website, along with recordings of previous webinars that you may wish to take advantage of viewing if you were not able to join us live. Please use the chat function throughout the webinar. If you have any questions or comments, we'll be keeping an eye out for your thoughts and questions as we go. And closed captioning is available if you should need it in the settings. The next slide, please. So I'm thrilled to note that we've got a great lineup today of speakers to talk about the patient safety structural measure. I'll introduce each one prior to their actual session, but as you can see, we've got a great qualified panel here today, and I'm sure you're going to hear a lot of very valuable information. We thank the speakers for taking time out of their busy schedules to join us for this important webinar. Next slide, please. Right. Also, we want to thank all of you for your commitment to advancing patient and workforce safety, especially in challenging times, which in healthcare, it seems like it's always a challenging time for one reason or another. So we really appreciate seeing so many people who are committed to advancing patient and workforce safety through participation in this National Action Alliance. Next slide, please. So a few thoughts before we dive in. This gives the framing for today's session, our questions to run on. So we're going to talk a little bit about the patient safety structural measure and what it is. Many of you are probably already quite familiar with it. And if not, I think you will find that the elements of the measure and the domains that it covers are quite familiar because they are topics we've been talking about in patient safety for quite a long time. We're really going to zero in on specific tools and resources that organizations can use to support their efforts around the patient safety structural measure, in particular, achieving high levels of performance and improvement, which will be an ongoing journey for all organizations. And we'll have some specific examples of how some organizations are doing just that and working to support specific domains and parameters of the patient safety structural measure itself. Next slide, please. So with that, I'd like to introduce our first speaker for today, Marty Hatley. Marty is the Director of Advocacy and Policy for Patients for Patient Safety US, which he co-founded in 2021, and he is a principal of the Healthcare Patient Partnership Institute. Marty has been active for over 25 years in health system transformation and work on research projects and transformation campaigns that have been funded by many agencies, including CMS, AHRQ, PCORI, and others. He currently serves on the governance board of Patients for Patient Safety US, Certified Professionals in Patient Safety, and the Alliance for Integrated Medication Management. He is co-chair of Leapfrog Group's Patient and Family Engagement Expert Panel and sits on advisory boards with the Institute for Healthcare Improvement, the World Health Organization, and RLDatix, among many others. So it's my pleasure to turn it over to Marty. And Marty, just go ahead and unmute if you would.
Okay, okay.
Perfect, thank you.
Hello, everybody. It's great to be with you. Fran, thanks for that wonderful introduction. It always reminds me when you go through my sort of history how old I am. But it's a good thing to have been in this field for a long time and to have had such a positive experience really working with partners from federal agencies as well as the private sector. So Patients for Patient Safety, as you mentioned, Fran, it's a patient-led nonprofit. We came together in 2021 when we were concerned about patient safety drifting as a policy priority to really make sure that our country and all of the states in our country really prioritize patient safety as the challenging public health issue that it is. And our membership includes organizations agencies who share our mission of advancing patient safety, as well as individuals. So if people want to become a patient safety champion, they can do it through our organization. We'll do an orientation and kind of engage you in our work. So again, thank you very much for being here. So the patient safety structural measures, what we're talking about today, this was developed. Oh, thank you for that slide. This was developed through a measure development process. I was on the technical expert panel. It was done at Yale at the request of CMS. It was a really, oh, no, we're going back to that slide. It was a very robust technical expert panel. So there were about 25 people on it, I remember correctly, from all stakeholder sectors, but several patients with lived experience. And it was unusual in that way. Often patients with lived experience are brought onto these technical expert panels in kind of a tokenistic way, or at least that's what my organization fears. There might be one or two. This one, we had a real presence. And I would also say the bigger point is no matter what stakeholder sector you're from, you're probably a patient or a family member of a patient. And I would say patients and family members are also players in several other stakeholder roles. So it was just a really robust effort, and it produced a really ambitious patient safety structural measure. This builds on a strategy that CMS has been putting out there through its different kinds of quality improvement programs, primarily hospital-based, but not completely, to look at the structures as a complement to process measures and outcome measures. So the structural measures really go to leadership, they go to governance, they go to culture, they go to patient and family engagement. They go to things like moving beyond blaming as a first response to when we have an outcome that's unexpected. All of these have been real challenges over the course of the patient safety movement to progress and sustainability of progress. So it's just exciting to see this structural measure strategy grow. The first one had to do with maternal morbidity. This is actually the fifth or sixth in a series that's CMS has put into the field. There are 5 domains that you can see here in the structural measure. And the way it's organized is under each of the domains, there is a question. There are 5 questions, excuse me. And the way it works is that leadership that participate in the Medicare programs, basically all hospitals, are asked to attest to whether or not they have these 25, so 5 times 5 is 25 best practices in place in their organizations. There's no penalty for saying no. So you don't have to have these in place. You just have to answer the question, do you have them in place as a condition of participating in Medicare? And then the answers will be scored. So you have to answer yes to every question in a domain, to all 5 questions in each of the domains to get a point. So there'll be a total of 5 points that are available. And starting next year, those points will be published. So the public will have access to a score for hospitals that are implementing best patient safety practices. And frankly, hospitals will be able to see where they are vis-a-vis their competitors or their colleagues in other organizations. So I really like that strategy. It incentivizes innovation, it incentivizes improvement, and it also gives patients and families information that is actionable in the conversations we have and the choices we make about where to seek our care. So just to kind of highlight some of the things here, in this slide, the underlying portions really map to AHRQ tools that, as I think all probably know, have been in the field for quite a while. And there's been a lot of work at AHRQ over the last couple of decades to really produce more knowledge, more tools in patient safety. So that's what the underlying denotes. I'll just start with leadership commitment, the first slide, leadership commitment to eliminating preventable harm. So our hospital leaders have designated patient safety as a core value, and we have plans and metrics to accomplish that. And underneath this one, I actually put something that is not in the structural measure itself. It's in an attestation guide that CMS has also produced. If you look at the URL, the hyperlink at the top of this slide, it'll take you to the CMS website where not only the whole structural measure is there, but also the attestation guide and some other resources that CMS has produced to help organizations get to it. This also leadership commitment, going back to domain one, includes engaging governance boards and in particular notifying governance boards when there are serious safety events. This is, I think, a good example of a question in this tool that really pushes the envelope. I think there are many, many organizations, hospital organizations in this country that don't have a policy or haven't had a policy until this prompt to notify all of their board members within 3 business days of a serious safety event. So it really does kind of get to engaging all levels of the organization. Second domain is strategic planning and organizational policy. Here, the question is zero harm your goal? I mean, do you have that built into a policy document that aspirational goal is what you're going for? And this is particularly important to patients and families. I know it's been something that's been talked about back and forth as perhaps unattainable, perhaps it shouldn't be a goal, but from a patient and family point of view, anything less than this aspirational goal is not enough. So we pushed hard to see this recognized as a goal. Patient safety competencies. There's a lot of people in the workforce, especially after COVID, when there's been so much turnover, who express concern that they don't have the training and the competencies they need to do the job that they're assigned to do. So we were happy to see this implemented as one of the attestation questions. There's an action plan for workforce safety. I think COVID has really highlighted the fact that while patient safety is a top priority, workers also have concerns about safety, and it's important that the organization pay attention to that as well. Just culture policy that balances no blame and appropriate accountability. This is something that used to be a real given in this field. And a couple of years ago at IHI, actually the year before last, I was asked a question after I presented on the patient safety structural measure about what just culture is. And that was my kind of wake-up call that there's been so much change in the workforce that some of the things that we think of as just sort of givens in our sort of knowledge base, our organizational memory need to be refreshed. So good to see this question there. Third domain is culture of safety and learning systems. So do you do a hospital-wide culture of safety survey? And there are parameters there about how often those should be doing it, a couple of different options there. But again, that's an AHRQ tool that is front and center embedded in this patient safety structural measure. And then there's a sort of a multiple choice attestation question that probes, with, again, leadership of an organization, what high reliability organization practices they have going on in the organization. And this ranges from lean to rounding to teamwork, team steps training. So we underscored that because team steps training is again embedded in this particular question. And then, do hospitals participate in large-scale learning networks for patient safety? I ask this question every time I present. Are you participating in a large-scale learning network? Because there was a time when all hospitals were, at least most hospitals were. And I think the National Action Alliance qualifies, honestly. If you're active in the National Action Alliance, that qualifies as a learning network that you're a part of. So you can say yes to that question and get towards the point for this domain. Fourth domain is hospitals work with a PSO listed to AHRQ. They want to know which hospitals are part of PSOs and which ones aren't. And we have one of our PSO colleagues here today, Shannon, following me to hear more about what PSOs are doing to implement the patient safety structural measure. Communication resolution programs like candor. I hope candor is, or CRP, are terms that are becoming more familiar to people. I don't think it's the standard of care yet in all organizations across this country, but the evidence is really accumulating that the more open and honest you are with patients and families after an unexpected outcome, and the more support you give to your workforce to have difficult conversations about that, the better your learning is, the better your improvement activities are, and it doesn't really add to your liability exposure, which I think was a big fear at one point in time. So we're seeing this really gain traction. I'd encourage you all to really pay attention to this and the elements actually of the Candor Toolkit. Again, an AHRQ toolkit built from several demonstration projects are all listed in the structural measure. And then measuring the performance of your CRP. We were very happy to see this here. In fact, we lobbied for it because we're concerned that, when you have a kind of a candor program in place in your organization, there's a temptation to cherry pick, to use it in the clear liability cases, but perhaps not in cases that are more defensible if you choose to defend, to deny and defend, and as opposed to just practice open and honest communication as a core value of the organization. And finally, patient and family engagement. This is the space that I do the most work on, but do you have a patient and family advisory council? Does it include people who represent the populations that you serve? Is it involved in your patient safety work? Lots of organizations have patient and family advisory councils that steer clear, frankly, of patient safety work, and this is a prompt to change the direction of those PFACs. Um, Access to hospital records, we fought really hard to get a portal. We've implemented those portals, for better or worse. I just struggled with mine to get my medication records right this morning. But it's a great tool. It's a tool that really does empower patients to have better dialogue with their providers, be a better team player. We're very happy to see the language here that allows patients to submit comments, sometimes through messaging about corrections when we see them. And for me, that's very frequent. I think that's probably true for many other people who use their portal. And then visitation. Hospitals support the presence of families as members of the core team. This was something that really took a hit during COVID, as many of us will remember, and we're happy to see it reemphasized in this structural measure. So these are not all the best practices. Again, you can get the total text at that hyperlink, but it is just a really phenomenal and I think potentially game-changing. I'm going to say not potentially. It will be a game-changing tool to see what hospitals report and how patients use this information as we have good conversations in the informed consent process and elsewhere with our providers about where we're going to get our care. Okay, next slide, please. So it's also been really exciting to see. Next slide, please. There we go. The synergy across the different organizations that have been pushing forward on patient safety before the structural measure became a thing. So there was a national action plan on patient safety that has been developed through a lot of engagement of leading organizations by AHRQ and IHI. They were the co-chairs of this task force. It's been around for a number of years now. And the National Action Plan went, my mic was disabled. I don't know, I think it's back now. Can you hear me?
Yes, Marty, I can still hear you. You're good.
Okay, good. So after this patient safety structural measure was adopted into the Medicare program last year, IHI and HRQ got back to work in making sure that the National Action Plan maps to the patient safety structural measure. And I'd really encourage you to look at the self-assessment too that has been put together by IHI. It's revised. The new revision was put out first in November, but it's being promoted now. And it really helps you get to yes. So I think of the patient safety structural measure as sort of where we want to be. And the assessment tool, especially from IHI, helps you get there through different stages that you might have to go through in your organization. And then the National Action Alliance has been, I think, singing out of the same, engaging health systems around the same topics before the patient safety measure. And they've done a great job, I think, at aggregating all of the AHRQ tools that can help you say yes to these questions. And then also just improving the website and improving the dissemination and communication of these tools, again to a workforce that's changed considerably since some of these tools were put out. So I'm really excited to see just the synergy happening across these different initiatives that really are now aligned, because many of you will know that it's really hard to align measures sometimes with from place to place. And here we're doing it for you in some ways and with you in other ways, but really through AHRQ's leadership. So I hope that's helpful to you. There are many more resources that are available for this. I've even seen vendors come up with new tools, as well as the tools that AHRQ and IHI and CMS itself have put out that we're going to be talking about more here. Okay, Fran, I think that gives an overview. I hope it does to our crowd here today, and I'll back to you on this.
Great. Thanks so much, Marty. That was a really great overview, done very quickly. We could have easily spent the hour on that. Before we move on to our next speaker, I'll just point out some things that are in the chat because people have been asking some questions. There's a link to the August 20th webinar from last year where we talked about patient safety competencies. That was a fantastic webinar with Lily Galinas from the University of North Texas sharing what they're doing. It got a lot of great feedback. There are also links. Patricia McGaffigan, thank you for putting in the IHI self-assessment. Patricia's from IHI and put in a link to the self-assessment tool that Marty just talked about. And there are a few other things in there as well. And yes, the recording will be available after today. Not immediately, but it will be posted to the National Action Alliance website. We'll get to questions at the end. I'm going to keep us moving, and it's my pleasure next to introduce Shannon Davila. Shannon currently serves as the Executive Director of ECRI's Total Systems Safety and has a clinical background in adult critical care nursing, specializing in infection prevention, patient safety, and healthcare quality improvement. She currently sits on the National Steering Committee for Patient Safety. She's authored a book and several articles that focus on the importance of infection prevention and patient safety. She's been recognized by AHRQ twice, in 2016 with a Heroes of Infection Prevention Award, and in 2020 became an AHRQ Fellow. She has served in the United States Air Force, is appointed to sit on the New Jersey Commission for Women Veterans, and leads ECRI's Saylight program. She's got multiple certifications, including a Team Steps Master Trainer and High Reliability Coach. So it is my pleasure to turn it over now to Shannon.
Thank you, Fran. Hi, everybody. It's great to be here with you today. Thanks for taking time out of your day to learn about this. So if we could just go to the next slide, please. So as Marty talked about, the National Action Plan, which is in really total alignment with the Patient Safety Structural Measure, one of the 4 domains of the National Action Plan is engaging patients, families, and caregivers. And as we know from, sorry, just gonna have to chat. As we know from systems theory and safety science, there are lots of different strengths associated with the actions or interventions that we use on a day-to-day basis to implement safety improvements, including engaging patients and families. And when it comes to partnering with patients, families, and caregivers, oftentimes education is our solution, right? We want to provide them with education. We want to do training. We want to give them all this really good information. But what we really know is that education is a very low level, weak action, and it doesn't facilitate the type of action that Marty was talking about that we really need. So when we want to think about our strength hierarchy, we want to think about how we can create systems and pathways for patients, families, and caregivers to really become activated and engaged in reporting safety concerns. So if we go to the next slide, a big part of doing this is using a learning system framework. And my organization, ECRI, and the ISMP PSO, we facilitate a learning system in a lot of what we do. Specifically, what I'm here to talk to you all about today, as an example, is our safety collaborative. And currently, we have to do an annual safety collaborative. And currently, our safety collaborative has about 25 hospitals that are focused on activating patients, families, and caregivers as partners in safety. And we do that through sharing, networking, analyzing data, all the things that you see in that framework here on the slide. So if we go to the next slide. Perfect, thank you. Now, under the PSO protections, in this collaborative, we are able to analyze different data. We're able to learn and share about high strength interventions that can really help bridge that gap between patients and patient safety. Now, you see here on the slide, these are the goals of our collaborative, right? So identify what are those barriers, facilitate and formulate strategies to implement high impact, and then ultimately to improve outcomes. So let's go to the next slide, please. Oh, other direction. I think we went backwards. Perfect. Okay. So the 2 primary focus areas that are collaborative and how they tie to the patient safety structural measure are, number 1, the safety assessment. And specifically under domain 1, and you see on here that first bullet that hospitals will work with their C-suite leaders to oversee a system-wide assessment on safety. And as part of our collaborative, we do have an assessment piece. We actually use the National Action Plans assessment that Marty spoke about. It is referenced in the CMS interpretive guidance for the PSSM as an example of an assessment tool to use. So we've used that for our collaborative. The second piece is really collaborating with SMEs. For example, we had Marty and Sue participate in our collaborative as subject matter experts to share best practices and really pragmatic examples of tools to help facilitate hospitals to incorporate patient and caregiver input around patient safety events, which is that second bullet you see here, which ties to domain number 5. So let's talk a little bit more about how we did this. If we go to the next slide. So the National Action Plan Assessment, as I mentioned, we use this in our PSO as part of a lot of different activities that we do. The action plan was created by the 27 organizations, including AHRQ and AHRQ and IHI, that co-chair the National Steering Committee for Patient Safety. It is a systems assessment. The results can serve as a roadmap for improvement, and it is very aligned with the patient safety structural measure. The assessment is broken into 4 key areas. And basically, an organization would go through each of those 4 key areas. There's several statements, and I'm going to show you just an example in here in just a second. And then you choose the statement that best describes your current state of maturity around safety. And then you get a score. So you could be just beginning all the way up to exemplary performance. I want to say that this is not about comparing your hospital to any other hospital. This is really about where are you at on your journey. And if you're on the journey, whether you're just beginning all the way up to an exemplary performer, then we applaud that. We want people to be on that journey. So if we go to the next slide, this is just a snip from what the assessment is. And you can see here that this is from domain patient and family and caregiver engagement. And I put a little star next to the element around escalation of safety concerns. And so what an organization would do is they would group their leaders together, their stakeholders together, and then they would read through these statements and really see where they land. What best describes the level of maturity that their organization is at right now? Now, when a few slides back, don't go back in slides, but on the slide that showed the PSSM metric, it said that hospitals must incorporate patient and caregiver input about patient safety events. And so when we use this assessment tool, we work through these statements that you see here, and we say, well, which score best describes that? What score do we want to get to? And really, if you think about score 1, that's just having the action in place for patients and family care and caregivers to escalate. But to really be able to show that you're taking that input about patient safety events into your process, you need to be, getting up there to a 3 or a 4. And so this is where it really comes into building that plan, building that roadmap, being strategically thoughtful about where you want to go. So if we go to the next slide, just want to show you some of our results that we have from our data at AHRQ around this particular area of the assessment. And you can see here that 40% of our respondents are just beginning. And that's great. We are excited that they are on the journey. Now, we do have others that are making significant impact, making progress, and exemplary, which is wonderful too, because they really serve as role models and examples of best practices for those that are on that journey. But I just want everyone to know, if you're just beginning, you are not alone. You are in good company. And this is how we're going to learn as a country how to improve our practices. So if we go to the next slide, what are some of the takeaways that we talked about in our collaborative when we work with our hospitals that are working towards this? Marty mentioned that we're in a place now where policy change is really needed. We need to start to hardwire some of these practices into our system. And one of the ways that we do that is to really understand how these processes fit, How are we going to measure them? What are we going to do with that information? We talk a lot about, when you implement something like a process to escalate patient safety concerns, what are the major challenges to implementing that? There's a lot. This isn't something that happens overnight. There's IT, there's patient advocacy, there's legal, there's patient engagement. There's a lot of people involved in these conversations. But also, as you're identifying those challenges, also be thinking about what are the solutions that are going to overcome those challenges. That is how we're going to be successful. Some other things just to consider that we've talked about in our collaborative about how to report and categorize the type of patient safety concern that was reported. Was it, did it impact the patient's, financials? Was it emotional harm? Was it physical harm? Assessing the severity of the safety issue. And we've seen organizations that have used, the AHRQ harm score, the NIC-MERP score. Some have created their own severity scores, but it's important to be able to start to quantify what type of harm that we're seeing with our patients. And then identifying what the appropriate response is. And this is where communication and resolution really comes in, because is this something that, is going to require that we determine a financial resolution for this patient and family? Is this something that we're going to do service recovery for? Is this something, that we need to even think more broadly about? So all of these things are really key. And I will say that the National Action Plan assessment tool that was co-created by AHRQ has been just an amazing tool to help our hospitals get on that pathway. So I'm going to turn it back to Fran.
Great. Thank you so much, Shannon. That was great. And we've got some really great questions in the chat that we will circle back to after we hear from our third speaker for today, Dr. Dawn Evans. Dr. Evans is a patient safety and quality professional with over 15 years of experience and has been a registered nurse for over 30 years. Dawn currently serves as the Director of Patient Safety, Quality, and Infection Prevention at Barton Health in South Lake Tahoe, California. She has a Doctorate of Nursing practice degree, is a certified professional in patient safety, CPHQ, and is also, like Shannon, a Team STEP master trainer. Dr. Evans has spearheaded various initiatives at Barton Health, including organizational-wide daily safety briefs, implementation of team steps, establishment of a patient and family advisory council, and she recently presented her doctoral project findings at the American Society for Healthcare Risk Managers and the NAHQ Next National Conference. So with that, it is my pleasure to turn it over to Dawn.
Thank you, Fran, for that warm introduction. Appreciate it. And hello, everyone. Good afternoon, good morning, wherever you are in this world. My name is Dawn Evans, and I'll be talking about some of the patient safety structural measure attestations within domains 2 and 3 and how we can leverage team steps to assist with these. And really, I'm going to be looking at application of these. So for those of you that are in healthcare settings where you will be attesting to the PSSM next spring, hopefully my experience here at my organization will help you as well. Next slide, please. Next slide. And go one more slide, please. Thank you. All right. So within the PSSM, Domain 2 on strategic planning and organizational policy, attestation D focuses on the hospital's implementation of patient safety curriculum and competencies for clinical and non-clinical staff. Now, this includes our C-suite executives as well as our governing board members, and we have to have regular assessments of these competencies for roles and action plans for advancing safety skills and behaviors. And I know watching the chat feed, there's been a lot of questions around competencies, so hopefully this will help. For patient safety curriculum, CMS listed evidence-based examples within their attestation guide that you can find online. These include CUSP, which is the Comprehensive Unit-Based Safety Program, AHRQ's Candor Toolkit, CDC's Infection Control Assessment and Response Program and Tool, Team STEP's Communication Framework, IHI, RCA resources, shared decision making, tools to reduce central line infections, utilization of data analytics, performance improvement methodologies, think of PDSA, Lean Six Sigma, and ethical standards. Team STEPS is bolded here as it also aligns with PSSM Domain 3. Next slide, please. So within Domain 3, there's a focus on culture, safety, and learning health systems. Attestation 3D specifically requires a hospital to implement a minimum of 4 of the 7 following high reliability practices. And these include tiered and escalating safety huddles at least 5 days a week, where one of those days is a weekend. And you have to include key clinical and non-clinical units and leaders with a method in place for follow-up on those issues that are identified. Hospital leaders participate in monthly rounding for safety on all units. Now, our C-suite executives, we know they're really busy, and so the request was they need to round at least quarterly. And there does need to be a method in place for follow-up on issues identified. A data infrastructure to measure safety based on patient safety evidence. Think of systematic reviews, clinical practice guidelines, national guidelines, and data from your electronic health record that enables identification and tracking of serious safety events and precursor events. The data are shared with your C-suite at least monthly and the governing board at their regularly scheduled meetings. Technologies, including computerized physician order entry systems and barcode medication administration systems, these promote safety and are really standardized ways of providing care to our patients that are based off evidence. The use of a defined improvement method or hybrid, such as, again, Lean, Six Sigma, PDSA, and some other high reliability framework. Team communication and collaboration training for all staff. And finally, your seventh option is the use of human factors engineering principles in the selection and design of devices, equipment, and processes. So you'll see that Team Steps is woven into this specific attestation in 3D because it's bolded here, and it touches on the high reliability practices of tiered and escalating safety huddles 5 days a week, again with one of those being on a weekend, and team communication and collaboration training for all staff. So as Team Steps came up in both domains 2 and 3, let's talk about how I was able to lead my organization to sustain success using this program. Next slide, please. Thank you. For those who may not be familiar with Team Steps, it's an acronym and it's short for Team Strategies and Tools to Enhance Performance and Patient Safety. It's an evidence-based framework that's been around for nearly 20 years, and it focuses on the 4 areas of communication, team leadership, situation monitoring, and mutual respect. Team Steps really helps organizations achieve high reliability across the entire healthcare system while delivering safe and effective care. And it's appropriate for your outpatient setting, your acute care settings, your home health, your skilled nursing, long-term care, rehab, really anywhere across the organization. And it's valid and helpful for both your clinical and non-clinical departments. Next slide, please. So within the domains, remember they focused on communication frameworks, and Team Steps touches on these. We emphasize the following tools at our organization because we found them to be the most applicable to everyone. However, the other tools such as SBAR are definitely used by our clinical teams and are taught separately. We talk about teach back with patients so we can ensure there's a shared mental model between what we're trying to educate on and the patient's understanding. This really gives us the opportunity to identify if there's any gaps where if we were to correct them right then and there, we would actually have that patient be more successful in their health journey. We emphasize closed loop communication, allowing confirmation of what was received and the importance of call out and check back to ensure clarity and a shared mental model among those team members. We talk about the 2 challenge rule and how to use that to stop the line, along with Team Steps CUS, which is an acronym for I'm concerned, I'm uncomfortable, this is a safety issue. We provide examples for each of these tools as we go through them during our training sessions. Next slide, please. Thank you. When we look at attestation 3D related to high reliability practices and tiered daily safety huddles, Team Steps briefs and organizational daily safety briefs meet this element for us. Clinical and non-clinical departments are trained on shift briefs as one of the first tools that we trained on here when we started implementing Team Steps. Briefs help to communicate and identify any new issues or concerns, as well as who's working that shift, who's our leaders, right? Are there issues going on that we need to know about short term, or are there things coming down the pike that are long term? We also encourage our departments to customize the content that they needed to hear in the briefs because every department is a little bit different. And so the information that would be of value to them, we left that up to them to decide. Now, we teach to huddles as well, and huddles are performed among team members as situations change and events emerge that require a quick gathering to regain situational awareness and adjust resources as needed. This is most apparent in our emergency department. For instance, when we have mass casualty incidents come in, that team will huddle and they will identify where they need to reassign or adjust resources. Debriefs occur at the end of shifts and after patient or significant events occur. These focus on what went well, what could be done better, and what needs to be done differently. Completed debriefs are returned to the area leader and the patient safety department for review and dissemination to appropriate teams. And that includes committees that will review these findings. So for instance, after a patient event such as a code blue, that gets debriefed and we actually review those findings and send them up to our code blue committee and have been successful in implementing change there. Now, going back to briefs, our department brief information escalates up to our virtual daily safety brief. This is attended by over 28 departments across our healthcare organization. It also includes our chiefs and our governing board when they are meeting during their meetings. I actually go and present the DSB in front of them. We provide counts on days since our last harm events. We include things like employee injuries. We hear from our administrator on call if they received any calls overnight. We offer announcements, and here's the most important thing, or one of them. We celebrate our good catches, right? Because we need to reinforce the positive. From there, we go into our department reports, and we use a color-coded system for our staffing for our non-ratio units. And because I'm in California, we have some units that are ratio, and so they'll tell us their census and their staffing to make sure we are in compliance with our ratios. Our DSBs occur 7 days a week, and we've been successful in this by having our patient safety department and that team lead during the traditional work week. And then on weekends and holidays, our house supervisors take over. They lead a shortened version, and that's primarily due to not all areas being open on the weekends or holidays. Issues are identified and escalated, and if it impacts a team, we ask that the leaders or the individuals attending go back, add this information to a team huddle. So again, we're creating and maintaining a shared mental model for the day. In addition to that, we take our daily safety brief information, we write it up, and we send it out daily to all of our leaders. And we also place it in a shared drive if anybody needs to go back and quickly reference the report for a certain day. To ensure transparency, we take it to the next step and we publish a weekly newsletter. It's called The Brief, and we email it out every Friday to all of our team members, our providers, and our governing board members. The brief provides a summary of not only the good catches, but any other items that we discussed that week during the daily safety brief. It also speaks to any emerging events or other trends and information that's helpful for all staff to be made aware of, and assists again with transparency. Next slide, please. Thank you. So these graphs show our daily safety brief weekday statistics, and we commenced these nearly 10 years ago. The graph on the left is our attendance rates just for 2024. And you can see we did have pretty good overall attendance with a dip in April, and it was only down to 91%. But for the year overall, we had a 94% attendance rate. Please remember that this is for 28 different departments reporting out. It represents inpatient, outpatient, clinical, and non-clinical areas. The graph on the right shows some additional statistics from 2024. There's a blue line near the bottom that shows our minutes per meeting, which averaged out to be 7.28 for the entire year. So daily, it's around 7 to 8 minutes. And so we're really proud of that because it shows that we're really integrating and quickly going through this daily safety brief. The green line is the number of days to close out those issues, which is the required follow-up piece for attestation 3D. We averaged 6.98 days in 2024. Now, it's interesting that when you look at April, where we had slightly lower weekday attendance, we actually had higher days to close out our issues. And that's most likely because the departments that may have been the owners of those issues were probably not in attendance to tell us and provide us with updates on the status of those action items. Now, I also want you to look at August because we had better attendance, but we still had some longer days to close. And sometimes this happens. It's usually more related to something like an information technology issue where it's just taking us longer to work through that system improvement or remediation. Or there could have been a physical plant issue that just took longer to get that action item resolved. With regard to our weekend holidays, because I'm sure you're curious about that, I didn't include those graphs here, but I can share with you that they average 3 to 4 minutes. This is for 17 different departments, and it's primarily hospital-based because, again, a lot of our outpatient clinics are closed on the weekends and holidays. However, it does still include clinical and non-clinical departments, and our administrator on call does attend these meetings as well. So as you can see, our DSBs are tiered, escalating, occurs 7 days a week. They include our clinical and non-clinical team members. They address follow-up action items, and as required through Attestation 3D, we're really proud of this program. Next step, please. Thank you. All right, so you may be wondering, how do we do this? And it has not been a quick journey. We've actually been engaging this, again, for well over a decade. So initially, we trained each department separately on just one tool. We wanted to go kind of slow and steady, and that tool was the brief. As more and more departments became trained and involved, we then moved it to our monthly new hire general orientation. And that's where it has resided for several years now. So general orientation includes clinical and non-clinical team members for us, and it's where they're taught team steps communication framework and the leadership skills we've just reviewed. We watch videos of high reliability teams and perform activities that reinforce these tools. New hires are provided with handouts to help reinforce the tools, as well as a copy of our Team Steps debrief form. Our debrief forms are also available on our internal website, as well as on every single crash cart. We want to make it very easy for people to go ahead and debrief. When I'm teaching to debriefs, I'm also fortunate that I can tie this into our event reporting training, which is really helpful because usually if you're debriefed something, we want to have an event report on it as well. So it's a nice bridge there to speak about the two different systems. And finally, and most importantly, I empower the individuals to speak up and lead debriefs and reach out if they have any questions or concerns. They are our eyes and ears and know best what's going on across our healthcare system. So I really lean into them. So I hope that you found this helpful in thinking about how you can apply Team Steps to the PSSM and how you can leverage that to attest positively for some of these different domains and attestations within the domains. Thanks for this opportunity to share how my organization's leveraging Team Steps to meet PSSM requirements. Fran?
Great. Thank you so much, Dawn. We've got several questions that have come in the chat during the presentation, so I will read them off. I've been saving them, and I would invite Shannon and Marty and Dawn to all please turn your cameras on. I will try to direct the questions to the best person based on my assessment, and I invite all of you to weigh in if you have a response. So the first question came from Dawn Farrell Harkins, and Marty, I'll toss this one to you to start. What does the validation process look like for attestations and structural measures?
There really is not a validation process for this. I would say that is sort of the biggest identified potential weakness of this, is that it could be easy to say yes when you're not really doing it. And we're seeing a little bit of evidence about that. We're also seeing some organizations, consulting organizations out there coaching people on how to get to yes in ways that probably are not as authentic as we'd like to see them be. So I think that is going to be something we have to watch. When we look at other programs like this, let's take the Leapfrog Group grades, for example, sort of society conspires to go, oh, that hospital doesn't really deserve a B or an A because this has happened or that's happened. So I think I'm going to put out a call to all of us to do our best as committed patient safety advocates to, speak up and do our part to try to make sure that the attestations are valid. There are pieces of it. There are some learning collaboratives that have verification requirements. So there are pieces of it that are verified. I'm particularly familiar with the Candor program. There is some verification going on in some learning collaboratives, but anyway, I think it's something we've got to keep our eyes on.
Okay.
Or
And
no,
either
Bob.
the others, thanks, Marty. Either Shannon or Dawn, do you want to add anything to Marty's comment? No? Okay, great. Let's go to the next question. Shannon, I'll ask you to take a first stab at this one. This came from Beth Miller. Can someone speak to the difference between having a policy versus having guidelines and standards? Would guidelines and standards meet the intent of the domain that asks for policy?
So I can't comment if guidelines and standards would meet the intent of the policy. I can't speak for how CMS would interpret that. But I do think when you have a policy in place, I think that it sets a certain standard of expectation. Generally, you would want to have some kind of measurements, audit measurements associated with following that policy, outcomes of the interventions described within that policy. But I can't speak to exactly, if CMS, if you could argue, well, we have a guideline that we follow versus having a policy, especially if the standard specifically calls out a policy. I'm not sure if Dawn or Marty have anything to add to that.
I'll add to that. There is a new program that IHI is launching, a recognition program for hospitals that are doing and systems that are doing this well. It's still in the very early stages, but we've got our first cohort and we're looking at so this is a kind of validation as well. We're looking at the evidence they have for meeting the expectations of the structural measure. And we're looking at guidelines documents as long as they're a guideline that is approved or adopted in some way by the organization. So I think a guideline that would perhaps come from a specialty society that hasn't really been through the approval process in the hospital may not make it, but a hospital guideline I think would qualify. I see Dawn nodding.
Okay, great. Thank you both. Okay, we've got a few more questions here on this. I'm going to jump around a little bit because they came in at different times. So Dawn, I think this one might be best suited for you. This comes from Raquel Layton. Does a new hire orientation count for the attestation, or do you have to go back and have all current staff trained?
Yeah, that's a great question, right? So you definitely, well, let me just say, new hire certainly, right? But then how do you have that ongoing validation of competencies, right? And so I know we have developed an ongoing annual review module, if you will, that's put in internally through our learning management system, and where we do provide those reminders on these core things within our organization, and staff members just go through, review the curriculum and take a quick test. And that's that ongoing competency, right? Because if we don't have that, then we could certainly have drift and we could lose the momentum that we've gained. And so that's how we maintain that. Plus, having a daily safety brief that everybody's attending, it really is that sustainment there as well, at least on that tool. I think you have to look at it and what best suits your organization. But definitely the attestation in 3D is the competency assessments.
Great. All right. Thank you, Dawn. So we had 3 questions come in from Danik Banaby. We may not get to all 3, so I'll start with the first one, and we'll let the group decide which one of you would like to answer. Does your work help promote health and safety of the future demographics of the general population?
I'll jump into that. Part of the PFAC guideline is, does your PFAC represent the populations you serve? So there's a thought there that it's important that we be tailoring our programs and getting the input from patients and families from the populations we serve. And I'll just say from my organization, because that was part of the question, we are going to continue to pay attention to disparities in outcomes, especially those that are experienced by certain population groups that we know are more at risk for an unexpected outcome. I know that can be a controversial issue right now, but it's important that we do that. The data is there. There are certain population groups that are more exposed, disabled people, older people, people of color. And it's important that I think we pay attention to those disparities and those data.
Thanks, Marty. Dawn or Shannon, anything you want to add?
I mean, I would just chime in too that as you're thinking about, again, kind of focused on the patient, family, and caregiver aspect of this, think about how your patient population, what's the best way to, how do they learn? What's the best way that they engage? Certainly we have people that engage, they prefer to text, they prefer to use digital means of communication. We have others that, like the old fashioned letter, right? Even though a lot of schools don't even teach cursive anymore. But so I think, when you're thinking about your who you're working with and you're thinking about the different demographics, I think it's also it's important to understand how they process information and how they feel comfortable in sharing that information back.
Okay, we had a second question from Beth Miller. Shannon, I'll start with you on this one. What mechanisms of communication can be used to notify boards of serious safety events that remain PSO protected?
Yeah, well, first of all, I would say that if you belong to a PSO, your organization should have a patient safety evaluation system policy in place, not a protocol, a policy. And within that policy, you will define, who is, how, who looks at the patient safety events, how that information is shared with the board. So as long as you define that within your patient safety evaluation policy, and I do believe that sharing, doing that huddle within 24, 74 hours, 72 hours with your board, that is all in the aspect of providing patient safety, which is one of the core, 8 requirements of PSOs. And so as long as you define that within your PSCS, your confidentiality and privilege protections will be maintained.
Okay. Thank you, Shannon.
Can I jump in? Because this really falls into my domain. I oversee our event reporting system with my organization. I'm also, because I wear many hats, I'm a small and rural organization. I'm the one notifying our C-suite team, hey, we've got a serious safety event, right? And then I'm the one helping draft that letter to our governing board. So have a system in place, know that, hey, this came in, confirm that's the serious safety event first and foremost, right? Because we want the confirmed ones going all the way up to the governing board. Because remember, they have ultimate accountability and responsibility for the healthcare organization. And so we want to make sure we're transparent. Also, too, think about maybe you've got a template that you can pre-make, right? And how are you going to get that information out to those governing board members, right? Is it via email? Okay, if it's via email, is it going to an organizational email or is it going to a personal email account? And be very mindful about how you're crafting that message, right? And give them what they need to know. And then what we do is we follow up with them in more detail during their governing board meetings where I am there and I personally give an update on those events. So I know it's a fine line. Your PSO definitely gives you some amazing protections too, but we have to balance that, notification within the 3 business days with the patient safety work product protections as well. So,
and Dawn, just final question, and then we've got to move to our wrap up. But within 3 business days, that's of the event being identified, correct?
That's correct. That's a confirmed event, right? Because if you're like me and you're looking at events coming in, you may just get something very minimal, right? But then it actually turns out to be something more significant. So for instance, a fall, we may not know immediately that there was or wasn't a fracture. It may be the patient starts complaining of pain hours later, right? And then we repeat diagnostic studies. We're like, oh, there is indeed a fracture, right? So you definitely want to take the time and do your investigation and get as much information together as possible. Once I am like, yep, I'm pretty sure this meets my protocol, is I go and I talk with my chiefs and then we collaborate on that. Oftentimes though, it's very clear cut. Here's the definition. Here's what I'm seeing. It definitely meets criteria, right? And from there, it's okay, let's go ahead and notify the governing board.
Great. All right. Thanks very much. If we could pull the slides back up, please. We've just got a couple of slides to share as we wrap up. and I'm just going to hit on a couple of highlights. So first, as we're wrapping up, we would like to hear from more of you in the chat. If you're hopefully willing to share with us, we'd like to know, based on what you learned today from our fabulous panel of 3 speakers, how will you support interventions in your organization to address the domains and the parameters of the patient safety structural measure from CMS? And so while folks are hopefully typing them into the chat, which will be a goldmine of information for us to look at afterwards, I'm going to go back and just note a few highlights from all of the presentations in reverse order of we heard them. I think, Dawn, two things I heard you say that I think are important for people to remember. Huddles can't be Monday to Friday during the day. They have to be all shifts, all days. Otherwise, they don't truly work. Structural tools for communication, like the CUS example that you gave, are absolutely, this ties into all the questions we had about competencies, because we can't just say to people, go out and communicate properly. We have to give them the tools and teach them how to do it. And we have to teach the recipients of the message on how to hear it and respond to it, which actually ties something, Shannon, that you said about appropriate response. That is the driver of safety culture, the response. And so we have to support people on how to do that. You also mentioned, Sharon, that this is about comparing the data to oneself, not to others. I remember one of my colleagues at IHI years ago used to say, benchmark the practice, not the data. So if you see somebody out there who's scoring better than you, don't get hung up on whether your score is lower than theirs. Find out what they're doing. That's what collaboratives like what Shannon is doing are all about. And then, Marty, a couple things that I think you mentioned are so important. In your slide, every domain, there is a tool from AHRQ. So you do not have to go out and how to figure out how to do this from scratch. There are multiple tools out there. We also have the tools from IHI and others. And as you started us off with, Marty, there is no penalty for saying no to any of the questions. So this is a just culture within the structural measure itself. If we could go to the next slide, please. Lots of great answers in the chat. I look forward to reading them. As we wrap up, the NAA newsletter is available. If you're not already subscribed, we encourage you to subscribe to that newsletter. You'll get a lot of information from it. All of the previous NAA webinars, as was noted in the chat, including the one from last August on competencies, are available. The recording and slides for this one will be available after today. And so that is a source for you to go back and revisit or share any webinars you may have missed. An upcoming webinar to mention to everyone, the Surveys on Patient Safety Culture program. We'll be scheduling a webinar in July about this structural measure and how the AHRQ surveys on patient safety culture, the SOPS hospital survey, and the shorter pulse version can be used to meet the requirements for domain 3. So please be on the lookout for further announcements to register, as the date and time are still being finalized. If you subscribe to that NAA newsletter, you will be in the loop and you will know. And for the summer, we will not be doing National Action Alliance monthly webinars, and we'll be looking forward to restarting with all of you during September when we have Patient Safety Week. So stay tuned for more to come, and you can watch the webinars that you may have missed previously. Great turnout today. Thank you again to Marty, Shannon, and Dawn for excellent presentations, and thank you to everyone who posted in chat. Have a great rest of your day, and we look forward to connecting with you all again in September. Thanks. Bye.
Thank you.